Any diagnosis we make, we have to treat it. Welcome back to ophthalmology for undergraduates and postgraduate beginners. Today we are going to see about cataract surgeries. Cataract surgeries are broadly classified into two types. One is ECCE, that means extracapsular cataract extraction. Other type of surgery is ICCE. What is that? Intracapsular cataract extraction. What is the difference between the two? Now you can see this is the normal eye where you can see the lens drawn in blue color. The blue color is intact here. So this blue color is drawn to indicate the capsule of the lens. Here the entire capsule is intact. When we do a intracapsular cataract extraction, here you can see that there is no blue color at all, there is no lens at all. Here the entire cataractous lens along with its capsule is completely removed. That is called as intracapsular cataract extraction. Now you see this picture. In this picture you can see this blue lens, but there is an opening in the anterior aspect. So in extracapsular cataract extraction, the anterior portion of the lens capsule is opened, through which the nucleus and cortex are removed out, and inside this capsule we can keep the intraocular lens or lens implant. So this is the difference between these two types of surgeries. Nowadays we don't do any ICCE because ICCE leads to complete removal of the lens with its capsule. So we cannot place a intraocular lens properly in the normal position and it may not give good vision to the patient. So this has become absolute. Okay, nowadays we don't do it at all. Extracapsular cataract extraction surgeries can be further classified as sutures involving cataract surgeries, sutureless cataract surgeries. The suture involving cataract surgery is called as conventional cataract surgeries. Sutureless cataract surgeries once again can be divided into manual sutureless cataract surgeries, machine assisted sutureless cataract surgeries. This is called as manual small incision cataract surgeries. This is called as Phacoemulsification surgeries. Nowadays very commonly spoken as laser surgeries in cataract. Actually, laser is not used to extract the cataractous lens. Laser only assists in certain steps of cataract surgeries. So, you should not call a cataract surgery as laser surgery. Conventional type of cataract surgeries with sutures are the first type of cataract surgeries done when IOL was invented. Nowadays, we rarely do this type of surgery, but this surgery should be done in case of complicated cataracts. When a patient is having a iridocyclitis or uveitis along with a cataract with certain complications inside the eye, this is the best type of surgery. This is an open type of surgery in cataract. In this type of surgery, the incision is about 10 millimeters in size and it is done at the junction of cornea and sclera, that is the limbus. We directly make the incision into the anterior chamber. It is a one plane incision that is being made. The incision is from 10 o'clock position to 2 o'clock position. So we directly enter into the anterior chamber, and when we go into the anterior chamber, what we do is, with the dilated pupil, I have drawn a small pupil here, but actually in cataract surgeries we dilate the pupil bigger. So once you dilate, you can see the lens in a bigger way. So we do a can opener type of capsulotomy. What is this can opener type of capsulotomy? You make multiple tears in the anterior capsule in a circular fashion. That is called as can opener type of capsulotomy. After making this, you connect all these tears and remove that portion of the anterior capsule. Once you remove that, what we do is we give pressure and counter pressure technique. We give pressure here over the cornea, we give counter pressure in the sclera, and we try to deliver the cataractus, cortex and nucleus as a whole. That is called as conventional type of cataract surgeries. Once we have removed that cortex and nucleus out of the eye, we remove the remaining cortex that is attached to the capsular bag. Then we implant the intraocular lens into the capsular bag, and after implanting that, we have to suture the wounds. I told that this is a single plane incision we have done to directly enter into the anterior chamber. So we cannot leave the patient without suturing. We have to suture the wound with 10-0 silk. So we place interrupted sutures like this and suture the wound so that the wound does not gap. So this is the type of conventional ECCE we do with sutures. This is a surgery now not so much followed, and this type of surgery has advantage because we can do in complicated types of cataract. The disadvantage is the patient has to take long time to recover from this surgery. So the recovery period is longer. Because we are suturing the wound and because the wound is very big, post-operatively the patient will have a astigmatic type of refractory error. So normally when we do a cataract surgery, we expect the vision to improve to normal. But sometimes because of the suturing and tightness of this wound and alteration in the shape of the cornea, astigmatism may result. The patient may need to wear spectacles to give a very good vision. So that is the disadvantage. The surgery is as such very cheap, very cheap. It is not very costly. It is very cheap for the patient, but the recovery period is longer and post-operative astigmatism is there. Nowadays, the most common type of cataract surgeries done are sutureless type of cataract surgeries. In sutureless type of cataract surgeries, unlike the conventional ECCE, we make a 3-plane incision. If you make a 3-plane incision, you don't need a sutures to close the wound after surgery. The wound will close on its own. So that is the idea behind the sutureless cataract surgeries. So I have drawn a picture of the eyeball with a cross section. This side I have written manual small incision cataract surgery, and this side I have written Phacoemulsification surgery. So in this you can see in manual small incision cataract surgery, behind the limbus, so this is the limbus, behind the limbus 2 millimeters away, that is in the sclera, we make a partial thickness incision. The sclera is about 1 millimeter in thickness, so we make a 0.5 millimeter vertical incision into the sclera, 2 millimeters away from the limbus. After making this partial incision in the sclera, we go through the layers, in between the layers of the sclera and cornea. So we split the layer, we go through the stroma of the sclera and cornea. So we go up to 2 millimeters inside the limbus into the cornea. So this is about 3.5 to 4 millimeters. So it is a tunnel we are making. That's a tunnel we are making inside the sclera and the cornea. Once we reach about 2 millimeters into the cornea, we once again turn the blade to make a vertical entry into the anterior chamber. So this is the third plane incision. So one plane is partial sclera, one plane splits the cornea and sclera into a tunnel, the third plane splits the inner portion of the cornea to enter into the anterior chamber. So this is a three planar incision we are doing in a manual small incision cataract surgery. In phacoemulsification, there we don't touch the sclera at all. We only do it in the clear cornea. So in the periphery of the cornea itself, we make a partial thickness vertical incision. We make a split in the cornea for about 2 millimeters. Then we make a vertical entry into the anterior chamber through the inner half of the cornea. So this is a three planar incision we do in a phacoemulsification surgery, which is done in the cornea alone. So you can see this picture where it is done in the sclera and cornea. You can see this picture where it is done in the periphery of the cornea. The size of the incision in these two types of surgeries is very important to discuss. The incision width is 7 millimeters in a manual small incision cataract surgery. The incision width is only 3.5 millimeters in phacoemulsification surgery. Nowadays, they have started to do a micro-phaco surgery. They are doing a phaco knit surgery. In micro-phaco surgery, the incision will be just 2 millimeter in width. In phaco knit surgery, the incision will be just like a prick with a needle, that is about 0.9 millimeters. So much of advances have come in this cataract surgery. What is the advantage of reducing this wound size? When you reduce the wound size, the patient recovers faster due to faster healing of the wound. When you reduce the wound size, astigmatism following surgery will reduce. Whatever surgery you do with the smaller incision, the more the small incision it is, the better prognosis, that is the visual acuity will be near to normal or normal itself. We need not expect any post-operative refractory errors in this patient. So that is the advantage of having smaller incision surgeries. Moreover, in these types of surgeries, we don't apply any sutures, so there is no chance of getting astigmatism once again. So that is why the wound size is being decreased with the advancement in cataract surgeries. In sutureless cataract surgeries, the type of capsulotomy we do in the anterior capsule is not a can opener type. It is a continuous curvilinear capsular rhexis. We call it as CCC or CCC. Continuous curvilinear capsular rhexis. Here we don't make multiple openings to join it and remove it. We just slowly tear the capsule in the center portion for about a diameter of about 6.5 to 7 millimeters, and we remove the center portion of the anterior capsule. Why we do this? Because we are going to use machining phacoemulsification. Here we are not going to remove the cataractous portion of the lens by pressure and counter pressure technique. We are going to bring the cataractous portion by rotating it above to the anterior chamber and then removing it. So that is the way we are going to do it. So in that step, it will not lead to the tear of the capsule. If the capsule tears in other portions apart from the center, sometimes you may not be able to keep the intraocular lens following this cataract extraction. In order to avoid that complication, we do a continuous curvilinear capsulorhexis. In manual small incision cataract surgery, after doing the central curvilinear capsulorhexis, you see here in this picture, the cataractous cortex and nucleus are inside this capsule. We bring this cataractous cortex and nucleus into the anterior chamber by rotating it, and we bring it to the anterior chamber. After we bringing into the anterior chamber, we remove through this 3-plane incision out. So that is what we do in a manual small incision cataract surgery. And after removing it, there will be some portions of cortex sticking to the capsular bag, so that we remove it also. After removing it, we put the intraocular lens, that is a prosthetic lens, into the bag, and we remove all the substances used for surgeries. Then after that, we put balanced salt solution into the anterior chamber. So naturally this 3-plane incision closes on its own due to the pressure inside the eyeball. So there is no need for suturing in this case. In phacoemulsification surgeries, after doing this capsulorhexis, that is a central curvilinear capsulorhexis, through the 3-planar incision made in the clear corneal periphery, we take the ultrasonic probe, that is a phacoemulsifier probe, and we reach the capsule. In the capsule, you see that the cataractous portion is broken down into pieces. We break the nucleus and cortex into multiple pieces, and after breaking them, what we do is we slowly eat each piece using that ultrasonic probe. That phacoemulsifier, emulsifies each one of these pieces and it aspirates it into the machine. So that way we remove all the cataractous portion from the capsular bag. After removing this, we have to place the intraocular lens. I said in small incision cataract surgeries, we can place a full size intraocular lens through a 7 mm incision. But here we are making only a 3.5 mm width incision, so it is not possible to insert a full lens IOL into the eye through that wound. The diameter of the IOL is about 6.5 millimeters. So it is not possible to enter to a 3.5 millimeter wound. So we need a special type of IOL in this case, that is called as foldable IOL. So you can see this is IOL, this is a foldable IOL. So the circular portion is folded like this. So it becomes only 3.25 millimeter. So we can insert through this wound, which is only 3.5 millimeters, and we can place the IOL in the capsular bag. Once we go there, this fold will release and there will be a full size IOL inside. So this is called as phacoemulsification surgery. The manual small incision cataract surgery does not need any costly machines, so it is somewhat cheaper than the phacoemulsification surgery. Here, because of the very small incision we are making, we have to break the cataractous lens into multiple pieces, emulsify it and aspirate it. So we need a costly equipment for that. That is a phacoemulsification machine. So we need a costly IOL also to be placed inside, because this is a foldable IOL. So the surgery is costly for the patient, but the advantage is the patient will recover very fast from the surgery. Post-operatively, the patient will not have any big astigmatism to wear spectacles for correction. But in manual small incision cataract surgeries, because the wound is about 7 millimeters, because we are placing the intraocular lens, normal rigid lens into the bag, what will happen is the recovery time is little bit more for the patient compared to phacoemulsification surgery. Because the wound is little bit bigger than a phacoemulsification surgery, the patient may land up in a small amount of astigmatism, which may need a spectacle to give a full correction for vision. So these are the different types of cataract surgeries we do. Nowadays, as I told, they have come with Micro-phaco, they have come with Phaco-knit, all the surgeries. In Phaco-knit, I told there is only 0.9 millimeter incision. in Micro-phaco there is only 2 millimeter incision. There it is not possible to insert even a foldable IOL. We need to insert a rolled up IOL. The IOL needs to be rolled up to a size of about 0.9 millimeters, because such a small incision we are doing. So these are called as rolled up IOLs. These rolled up IOLs are hydrophilic IOLs. These IOLs are dehydrated in the manufacturer company and they are giving it in a package. So we will insert into the bag, then this hydrophilic IOLs will drink up the balanced salt solution as well as the aqueous humor in the anterior chamber. They swell up to the normal size IOL. So that way it is being done in Micro-phaco and phaconet surgeries. So these are the different types of cataract surgeries we have discussed. Whenever we talk about the cataract surgeries, we have to talk about the IOLs also. IOLs are of three types. One is unifocal IOLs, multifocal IOLs and accommodative IOLs. Unifocal IOLs give vision only for one distance, either for distance or near. You have an optic in the IOL, you have a haptic in the IOL. This optic is going to give the vision. So this will be calculated either for distance or near. Usually we calculate the IOL power for distance only. This is usually carried out in case of bigger incision surgeries because we expect astigmatism in bigger incision surgeries. So we cannot keep these two lenses. These two lenses can cause problems for the patient. Next, coming to the multifocal IOLs, you have the same type of IOL here, but the optic portion will have multiple zones. The multiple zones will focus at multiple distances so that the patient will be able to see clearly each one of the distances away from him. So that is called as this multifocal IOLs. Multifocal IOLs are better done in case of phacoemulsification surgeries only, where astigmatism is very minimal. Next, coming to accommodative IOLs. Accommodative IOLs is nothing but the IOL will change its shape according to the distance we see. So that is the accommodative IOLs. These IOLs are still under research process. It has not commonly come to use in the public sector. So we are still there. We will definitely one day use this accommodative type of IOLs. With this, I am stopping today. We will discuss about some other topic in the next session. Thank you.